Good afternoon, everyone. My name is Maya Luria with TMC for Seniors, and today we're going to dive into the role of palliative care. I know that there are a lot of questions about what is palliative care and how does that differ maybe from hospice. And today I've got Dr. Shana Semmens here with me. She is the TMC Palliative Care Medical Director. This is a new program, I would say, within TMC. It's been around for a while, but 6 years. Oh my gosh, I didn't even realize it was that long. So thank you for that. But I want more people to know about what you do and how you might be able to help them, Dr. Semmens. So welcome.
Thank you so much for having me. Yes, it is a super common question, and it's even a common question amongst medical providers. So I think palliative care is a very new specialty in general and can be misunderstood. So I'm very excited and honored to be with you all today to kind of answer some of those questions.
Great. I'm going to go ahead and put your PowerPoint up for you. We do have an online audience that's watching along with an in-person audience. If you have a question and you're at home, please feel free to put those questions into the chat and I'll ask them at the end.
All right, thank you guys so much. So what is palliative care? The simplest form I can say is that we're here to relieve suffering. And so that may depend upon each individual person, what is causing suffering, what may cause suffering in the future. And so we individualize our approach to each unique patient. In general, palliative care is a medical specialty, and we used a team-based approach for anyone with serious illness. And I can go over all the different serious illness definitions in just a bit. Our aim is to improve quality of life of our patients, which also includes their families. We are often a support with other treatments. So any treatment that a patient may be seeking for their heart disease or their cancer or their lung disease, we can be used in conjunction, and we work together with those other medical specialists to make sure our patients are doing as well as possible for as long as possible. We're also very holistic in our approach, and we look at the whole person. And so that means not only your physical symptoms, but your psychosocial and spiritual needs. And often in the hospital, we're working very closely with our spiritual care team and our chaplains. And we have a social worker on our team as well to kind of really make sure that we're looking at the full spectrum of supports inside the hospital and outside of the hospital to help people with serious illness. What are the benefits of palliative care? So I know a lot of times with different medical specialties, we turn to the data and what does the research show us? And we have research in palliative care as well. And so there are ample articles, there's ample literature and data to show that it increases patient comfort. It increases comprehension of what's going on with my medical illness. I can't tell you how often I ask a patient what's going on with them in the hospital, and they're like, I don't really know. Because sometimes doctors speak in medical mumbo jumbo. And so sometimes I say that I'm a translator, and I translate that medical mumbo jumbo into English. And sometimes I'm translating from English to Spanish then too. So we've got multiple translational services. It increases family satisfaction with the care that they receive in the hospital and outside the hospital. It decreases things like depression, anxiety, and post-traumatic stress disorder. I think it's not something we like to talk about, but if you've ever seen a loved one in the intensive care unit in the hospital, it can be a very stressful environment. Things change sometimes minute by minute, but definitely hour by hour or day by day. And sometimes that uncertainty adds a lot of anxiety to a situation, and people can be kind of reliving those situations long after they're outside of the hospital. But it's been shown that if palliative care is there to help support them, those types of feelings that don't feel very good are decreased. It also decreases conflict. So we know that families are complicated and medical situations can be really stressful, and sometimes that heightens family issues. And so a lot of times it can help to have a kind of independent third party help mediate or facilitate conversations. So it's not one side of the family versus another side of a family, or one side of a family versus the patient, or even different doctors being at odds with each other. It also decreases hospital length of stay, and sometimes that includes length of stay in the ICU. And so I feel like in general, most people don't like being in the hospital longer than they need to be. And so sometimes we can make sure, based upon the patient's goals, that if the hospital isn't meeting those goals, maybe there's a different care plan for them that includes getting out of the hospital sooner. So what kind of patient might benefit from palliative care? I'm sure maybe some of you are wondering, do I need palliative care? Does my loved one need palliative care? So we often get consulted appropriately on patients who are in the hospital a lot. Sometimes patients have cancer, especially if that cancer has spread to different parts of their body, what's also known as like stage 4 or metastatic cancer. A lot of the patients that I take care of with different cancer diagnoses, I can help with pain management, nausea, constipation, any kind of those physical things that maybe their treatment is causing or the cancer itself is causing, and we're trying to make them feel better while they're going through their cancer treatment. Advanced heart disease is another good one. So this is someone who might have heart failure. Maybe they're in and out of the hospital a lot because it's really hard to keep that fluid off of their legs or off of their lungs. Maybe they've had a very major heart attack. Maybe they have a bad heart valve and they're trying to decide whether or not they're going to undergo a procedure to maybe fix that valve or not. Advanced lung disease is another subset of patients that I see a lot. Oftentimes this is patients with COPD or emphysema. Maybe they've been on oxygen at home and now they're coming into and out of the hospital a lot more. Maybe they have something called pulmonary fibrosis or kind of scarring of their lungs, and so they're needing extra help with breathing. And then other things like end-stage kidney disease, end-stage renal disease. Maybe they're on dialysis, but it's not making them feel as good as it did when they first started dialysis. Do we continue do we continue the dialysis or not? Or maybe my kidneys are getting worse. I don't really want to do that. What are my other options? Or maybe advanced liver disease. Maybe we have cirrhosis. Maybe we have other issues going on. Another really tricky one is advanced dementia. So I think what's really hard about patients with dementia is that there's kind of a gap when they're doing okay at home, they're not doing okay at home and we need more help, and then hospice is available to them. And that in the middle zone can be a big zone. And so how do we help with behaviors, or how do we help patients and their families think through of when it's maybe time to not be at home and be in a memory care facility? Or are there other things that we can help with, including things like depression that sometimes come along with different dementia diagnoses? I also see patients in the hospital maybe after something that's happened with their brain. Maybe that's a stroke or some sort of head injury. I often see patients in the hospital with just really severe infections. So we see a very wide range of patients, and I sometimes like to joke that anybody in the hospital, I can probably find some way to be helpful to you. But I think it's really, really important for those people who might need some extra time to sit down and really think about what's important to me, what do I want out of my medical care going forward, or how do I make sure that the medical care I receive is helping me get to the goals that I have. So in the hospital, and I mostly work in the hospital, we have a whole team. So there's doctors, nurse practitioners, we have a nurse, we have a social worker. We work really closely with our chaplains and our spiritual care team. We work really closely with our volunteer service team as well. I love to offer pet therapy because I have so many patients that miss their little, or maybe not so little dogs at home. And we have dogs in TMC that can come and kind of help out and give you a break in your day. So what we do whenever we get a new consult on a patient is we sit down with them and we give them our time and we get to know them as a human being, because I can't help make medical recommendations for you unless I know a little bit about you and what's important to you. We also help with symptom management. So this might be pain, nausea, constipation. I've helped people with dry mouth or other things that maybe can get overlooked easily, but I really kind of drill down to what are the things bugging you? What's bothering you physically and how can we help with that? And I have to tell you, so many times it's dry mouth. It's a really bothersome symptom and there are things that we can do to help. I put up our website here. We do have a website. So if you are thinking, oh, something about palliative care, I don't know, you can look at the TMC website and there's different resources for you there as well. So in the hospital or outside the hospital, but because I mostly work inside the hospital, here are some questions that we ask our patients really routinely that can kind of help maybe you guys think about, what does this palliative care thing mean and what might that happen? You know, if I had a palliative care doctor in the future, what might the things I need to be thinking about be? What's important to you? Often I get things like family as an answer. I had one lady tell me it was her cat, Tuna. That's what was important to her. I have a lot of people tell me taking care of themselves is really important to them. Sometimes golf comes up, sometimes painting. So think about just for a second for you, what is important to you? What matters to you? What are we hoping for? You know, sometimes I meet people and they just got a new diagnosis that maybe doesn't feel good. Oh my goodness. That spot on my lung, it's cancer. Okay, that's shifting things in my life. That's a big change. What am I hopeful for? Am I hopeful for more time? Am I hopeful for a cure? Am I hopeful for seeing my grandson graduate? Am I hopeful to get to that family reunion in Italy? Literally, I want to know those things so that I can help you get to those things. What fears or worries do you have about your illness or your medical care? This one's really important because I feel like most of the time my patients have deep, dark fears that they don't want to talk about with their family because they don't want to worry about giving up. They don't want to worry about being negative. But sometimes it's really important to get them out too. And sometimes those fears I can fix because it's something that we have a solution to. We often talk about the balance and trade-offs because unfortunately I can't give people everything they want, and sometimes their medical situation or their bodies aren't cooperating with their minds. So how would you approach the balance between living longer or quality of life? And what does quality of life mean to you? I have patients that quality of life means that I am independently living on my own with no help, and if I can't do it, I don't want it. And I have other patients that say, as long as I am physically having a heartbeat, I'm good. I want machines forever. And I have a lot of patients that are somewhere in the middle. Are there special activities or events that you're looking forward to? This is when I get the good stuff. The vow renewals, some sort of baby being born often comes up, graduations. Those are the fun ones because then we get to know our patients a little bit more. And then I get to see cute baby pictures sometimes too. So, you know, sometimes we ask what I call the hard questions because these are the questions that matter. These are those deep, dark questions sometimes, but they also help us really get to know you so that we can look at your medical situation and make a plan moving forward that makes sense for you. And another really important one is what sustains you or helps you when you face serious challenges. Sometimes that's religion. Sometimes that's special friends or family members. Sometimes that's being able to go out into nature to that special tree where I have a connection with something. And so those are really important too. You know, I ask these questions not only to get to know you, but to see what I can do with meeting you where you are in the hospital and bringing things to you. I've had medicine men come into the hospital and do drum ceremonies. I've had, you know, special pets come in. We are so lucky at TMC that we have so many windows, right? So even if there's a baby who can't come into the hospital, they can come to the window. These things matter a lot. And sometimes I also will just get you chocolate milk if that's all you want. Full service. So there are also clinic models. So in town, there are 2 main palliative care clinics. The Banner system has their palliative care clinic in the cancer center. So you have to be a Banner Cancer Center patient to access that clinic. And we have a very brand new teeny tiny itty bitty clinic through TMC1. I go there a half day every other week. And I see patients who I've seen in the hospital or who are otherwise connected and get referred into my clinic. So I have patients with cancer. I have a patient with ALS, all sorts of different diagnoses, and they're at a spectrum on their treatment plan and kind of help prepare for what might come. And we do the same things that we do in the hospital when we're doing it in a clinic. We get to know you as a person, we understand what your symptoms are, and we coordinate your care with your primary care provider, your other specialists, whatever that may be. Telehealth is an option with this clinic, but a lot of times there needs to be some in-person visits to make sure that we are treating you appropriately, physical exam matter, all those types of things. There are some home-based palliative care programs in town. I do this warning because most of them are offshoots of a hospice company. So a lot of times if you Google like Casa de la Luz in Tucson, like hospice will pop up, but they also have palliative care programs. I can't speak to exactly what these programs look like, and sometimes they're changing. This is the most updated list. My inpatient social worker every couple of months calls all of these programs to make sure they're still active, they're still enrolling new patients. In general, I tell my patients they can expect a nurse practitioner who comes to their home to visit them and check in on them about once a month. Sometimes it's more, sometimes it's less. It depends upon what the patient needs, but they do the same thing. We're getting to know you. We're helping you walk through advanced care planning documents. We're helping to understand where you are within your disease and what might be coming ahead. We're also pretty lucky here in Tucson in that we have kind of a resources outside of the hospital. So the Pima Council on Aging is another resource and can kind of help with different things that come up with palliative care. The Arizona End of Life Care Partnership is a resource that's through the United Way, and they're really working on trying to make sure that the community resources in town have a central location where everybody can access them. One really important up and coming resource is the Arizona Healthcare Directives Registry. And so that is actually an statewide initiative to be a cloud-based, technology-based system to house your advanced care planning documents. And we'll talk about those more in the future, but I know you guys probably know what it is. These are your living wills, your medical power of attorney, maybe your orange form or your post form. You can upload them to this website, and then no matter what hospital you go to in Arizona, what clinic you end up at, they can log into this website and see your wishes. I will say that this is brand new, but we have used it in the hospital. You can get a wallet card that says, hey, my directives are in the registry, and I have personally logged into the registry and found someone's wishes and was able to find contact information for their family members to really help support their care. We care so much in the hospital about making sure that you're the boss. Like you're the boss of you. I had an attending once tell me, we're doing it the Frank Sinatra way, like it's your way. And so if you have wishes about what you would or wouldn't want from your doctors, we want to know. We're asking about it in the emergency department. We're asking about it again when you come into the hospital, not because we maybe agree or not agree with your choices, but we really want to make sure that we're giving you the medical care that matches up with what you want and that you understand what's going on with you and your body so you can make the most informed decisions for yourself. And then your medical care team is a huge resource. I think, primary care physicians, former primary care physicians, so like disclosure that I used to do this with my own primary care patients, we care so much about you. We want to know that you know what's going on with your medical conditions, you know how things can get better, there's the option of things getting worse, and how we can help support you along those ways. And you asking about this, your PCP will be so excited. And you can have an entire outpatient primary care visit just dedicated to talking about your advanced care planning documents and your advanced directives. So that is something that, I think there's the illusion that there's no time to do that, but there's always the time to talk about the stuff that matters. And especially if you're bringing it up, your PCP is going to do a little happy dance and we'll be more than happy to help you. So speaking of advanced care planning documents, I feel like there's a lot of confusion about them. And so I actually brought some with me. So I'm going to pop over here and grab them. And then we're going to go through and talk about them. So the medical power of attorney is, if I had to pick one that's the most important, this is the most important document. And this is a document that says that if I'm unable to speak to myself, so I'm super confused, or I've had a stroke and I can't talk anymore, and the doctors want to know what to do with my medical care. Are we going to do CPR? Are we going to do X, Y, and Z? Who do they call? And what I often tell my patients is that it doesn't always have to be the like obvious choice. So in Arizona state law, if you're married, we automatically talk to your spouse. But I'm going to go ahead and throw my husband under the bus here. If something happened to me and I was in the emergency department and I couldn't talk for myself, my husband would be beside himself. And I don't think he would be in a good headspace to make good decisions for me. I think he would be emotional and he would be overwhelmed. And so my medical power of attorney is actually my friend. She knows me really well. She knows what I would want or what I wouldn't want. And she would be able to say that. And it's kind of me taking that pressure off of him in a way. And partly it's because my job and I see things, right? But he wouldn't be the best person. And sometimes the obvious person isn't the best person. Sometimes it's the best friend. Sometimes it's the sister. Or sometimes, let's say I'm a lot older and my husband has dementia. He's not the best person. He can't make these decisions. So maybe it's a friend or a daughter or whatever that may be. It's really important to know that this person can only make medical decisions for you if you cannot make them for yourself. And so it only goes into effect if you're unable to tell the doctors what you want. And this may be in flux. Maybe you're really, really sick and you're confused, but then you get better. Well, we go back to you. And then you can yell at your person if they did or didn't follow your wishes. So there are short forms. And then in living wills, there's also ways that you can do a medical power of attorney as part of your living will. So this is my personal favorite living will document. It is the Arizona Prepare for Your Care form. And you can go to Prepare for Your Care on Google and the website will come up. These documents are in English and Spanish, which is helpful. What I like about them, this is what I tell my patients, so you can laugh with me or not. It's in big font because sometimes we forget our glasses. So I like it that you can read it because some of these other forms are really teeny tiny or feel like they're in medical like legalese and it's very confusing. This one breaks it down really beautifully. And it's talking about who would your medical decision maker be on page 3. And then the different decisions that might come up with your medical care. So things like breathing machines or ventilators, things like CPR or chest compressions, things like dialysis. If your kidneys stop working, there's machines to filter your blood. Things like feeding tubes, whether they're temporary or semi-permanent. Things like blood transfusions. You know, we really want to know if you are maybe Jehovah's Witness and you don't want blood products. Or maybe you've been through a lot of stuff and you're like, I don't want a feeding tube if I can't eat on my own. We want to know that so that we don't do that for you. And then this form is also really great because it kind of talks about how strict should we be? Should we follow everything that you wrote down totally to the T, or is there some room for your medical decision maker to talk with the doctors about this unique situation? The other thing I really like about this form is that it talks about now and the future. So with my current medical condition now, what do I want? But if something changes in the future and I'm closer to end of life, would my choices change? And so me, for instance, I've got young babies at home. I'd want CPR. I'd want to give it a good chance. I want to be around for my kids. But when I'm 80 or 90 or whoever knows, maybe I don't want that anymore. And I'm going to tell you, my age is probably younger than that because that's just my choice. But you have your choices and I want to know what it is. And so this is a really great document. The reason I like this document too, and I have converted several of my intensive care physician friends to love this document too, is that it talks in general about what's important for you to be able to do. Is it that you want to be able to talk to your loved ones? Is it that you want to be able to eat on your own? What are the things that make your life feel like a quality life worth living? And some of the other forms that aren't my favorite, but they're better than nothing, just say, if I'm in a persistent vegetative state, I would or wouldn't want something. Well, I'm going to tell you right now, it's a very specific diagnosis that takes at least 3 months for us to diagnose, and it's not super duper helpful in the acute hospital setting. This one's more helpful. There are other living wills. 5 wishes is one. I see them right here too. This one is great because it kind of talks through all those same things, but this one even gets more detailed into like, well, what music do I want playing at my funeral? Or do I even want a funeral? And so this one isn't my go-to because sometimes I talk to people about this, and if I give them this form, they think that I'm trying not to tell them that they're dying, but they're dying, and that's not at all my intention. I don't want to scare people. So that's why I like this one. We don't talk about funerals quite yet. But this one can be really powerful too, and it's legally valid. The other great thing about 5 wishes, because I know I have a bunch of friends who have different situations, this has been translated into a bajillion languages. Like I can get my hands on an Arabic version or a Spanish version or you name it, it's been translated really, really beautifully. And that's really important to me too, that people are reading in their native language or their more comfortable language so they know what they're actually saying yes or no to. 2 other forms that are really important are the orange form. This is an out-of-hospital do not resuscitate form. So this form really talks about whether or not you would want CPR or a breathing tube and being hooked up to a ventilator or breathing machine. If you're like, no thank you, I don't want that ever, you should probably have one of these so that if something emergent happens in your home, we often say to post it in a very obvious location where emergency medical services might see it, like the fire department. And so that they know that you don't want that, so that your wishes kind of follow you into and out of the hospital. And so this one, it needs your name, your signature. It has a place for your medical power of attorney, so someone else to get a hold of if you're in such a situation that you need help. Your kind of description and a place for your photo so that we know that we're making sure that we're following the wishes of the correct person, and then a signature of a doctor. So primary care physicians can sign this. I sign this all the time in the hospital, just a medical professional. And then there's a place for a witness, just to make sure that you weren't coerced into this. This one is a state-specific form. So if you live here, during the winter and you live somewhere else in the summer, sign me up for that as soon as possible, please. We're getting hot already. But this doesn't necessarily translate to Minnesota or wherever else. This is a very Arizona-specific form. The form that I don't have with me, but it's here on the slide, is the POLST form. This is a physician order for life-sustaining treatment form. Some places it's called MOLST, but POLST, MOLST, anything OLSTy. This is, there's a national form too that's on bright pink paper. This is like an orange form, a DNR form, plus more. It has a section for would you want surgery or not? Would you want artificial nutrition or hydration? So a feeding tube or liquid through the IV or not? Would you want dialysis or not? And then it has another place for other. So this one can be really tailored to your unique situation. So let's say you have some chronic kidney disease and you've already talked with your family kidney doctor, primary care doctor, you don't want dialysis if it ever got to that point. You could write it on this form, and then wherever you go in the country, we would know about that. I did want to take this opportunity to talk about CPR just because there's so much confusion about CPR. And so this is what I tell my patients. TV and the movies have kind of shown CPR to be really something beneficial and easy to get through. And there is research and data to show that it fools even doctors or medical students into thinking that it's way more helpful than it is. Really, it was designed for middle-aged men with a heart blockage and having a heart attack until we can remove that blockage away, and then they're good to go. So it works okay for issues with the heart or easily reversible situations that would cause you to stop breathing or your heart to stop beating. But if the underlying reason that your heart is stopping or you're dying is because of something like cancer or kidney disease or other things, pressing on your heart doesn't fix those things, so it doesn't really work that well. And we have data about the survival of CPR, especially in the hospital, to going outside of the hospital. But that data doesn't say anything about what your mind is like. And it doesn't actually say where you're going, home versus a assisted living facility versus some sort of rehab facility or something like that. And so I put up some statistics here, not to be scary, because we definitely can have successful CPR outcomes. But just to say, like, If you have metastatic cancer, it's really probably going to do more harm than good for you, versus if you're 65 or 90, it's going to work differently. And that just has to do with how well everything else in your body is working. So just information, right? I think it's, we all aim to make really informed decisions, but when you don't know the information, then you may not be able to make the most informed decision for you possible. And again, this also matters in context with your goals. If your goal is to live as long as possible, CPR is for you. But if your goal is to remain as independent and independently functional as possible, CPR may not get you there. And so that's a conversation to have. And that's also why we ask about it every time you come into the hospital. Because what worked for you 5 years ago and what your decisions were 5 years ago might be different than now. Or if this is your 6th time to the hospital in the last 6 months, maybe things aren't going so well and maybe we need to talk about it one more time. Does that make sense?
Yes.
Okay. Is that different than maybe you thought about CPR in the past?
Mm-hmm.
Okay. And then I put in a slide about hospice just because whenever I talk about palliative care, people get confused. So we can talk about this or not. But what I love about this little graphic at the very bottom left is that palliative care is like a big umbrella and hospice is a kind of a piece of palliative care, but it's kind of a narrow area. We have a lot of the same goals about patient comfort and quality of life, but hospice is really when we know that this is an end-of-life scenario. Again, usually with less than 6 months anticipated as a life expectancy. Most hospice is done in the home, but there are ways to do it in other facilities. And again, it's really the shift from instead of wanting things like chemotherapy and coming to the hospital, I want to avoid those things. So they're similar but different, and palliative care is available to patients with serious illness for a much longer time, hopefully in a clinic setting or a hospital in an out type setting, and then hospice is for the future. I talk about hospice a lot in my job, I do, but we love when we get patients a lot sooner than having that conversation too. Okay, so I wanted to leave plenty of time for questions. Thank you so much for your attention, and thanks everyone online as well.
So thank you. I've got a couple of questions that I want to ask you because this is so important, and I want to make sure everyone understands. For instance, the post form. If you have the post form, does that trump all? If you had, let's say, you did all 3 of those, you did all your advanced directives. Which form trumps the others, I guess?
So that is an excellent question, and it's also an excellent question for, let's say you have a living will and then you want to do a new one.
Right.
So we look at the timestamp, so when it was signed, usually the most recent trumps the past ones.
Okay.
But if you have an orange form and a post form and they say the same things, then they're together. What's really important is just to make sure that all your documents match in their wishes, because if they don't, the most recent one wins.
Okay, so if somebody wanted to change anything, you want to make sure, and let's say you changed in your directives, you changed your proxy, but you have a post form that maybe indicates something different, or then do you have to go back and get that one redone?
Yeah, so yes is the short answer. So if you have a living will and it says that your medical power of attorney is Amy, and then we fast forward 3 years and now you want it to be Bill, you need to change that living will and that orange form so that they're matching. Oftentimes what I do when I'm talking to a patient about these forms is ask if they have any in the past. The most common answer is no, followed by I don't know. And so then we really work hard to make sure patients have copies so that they have their one for their medical power of attorney, one for them at home. We take a copy and scan it into the hospital system. And then now with this new advanced care directives registry, we're uploading it as well. So the most recent form matters the most, but it's really important to think about the forms you may have from before so that if you're making changes, they're congruent and they're all matching each other. Great question.
Great. And can you have more than one proxy on, on your advanced directives, and how does that work?
So yes, you can have as many people named as you want. And if you don't have someone named, then Arizona has a state law of who we would go to as your surrogate. So the recommendation I always give is that you have a primary person, like a one spokesperson, and then you have backups. But I have patients who are like, no, I want both my daughters to have to agree. And you're like, okay, well, then we have to wait for that. I have seen where sometimes that creates conflict and sometimes we have concerns. I've seen times where they're both like totally in agreement, or like one daughter totally defers to the other. So my recommendation is usually that you pick one person so that there's not potential conflict between two. But let's say you have 6 children and no spouse and no adult parents living, and you didn't have a document, then we would have to go with the majority of your 6 children. And so you would be looking to getting a hold of all of your children in the hospital, and sometimes that takes us a long time to try to find everyone. And so my recommendation is that you pick one, and then you have as many backups as you want. And the backups are great because I've seen a lot of things. Definitely had patients where they had like 3 people as their medical power of attorney, a primary, secondary, third choice, and they've all died. And so then I'm saying, okay, we got to pick someone else. So it's really nice to have some backups. The other question that sometimes comes up, because I have met patients who are like, all my family is dead. All my friends are dead. I am the last living person of everyone that I care about. And I'm like, well, do you have anybody else? And they say no. And then I say, well, then we need to talk about fiduciaries and like hiring someone that would be my power of attorney in the future and who could make these decisions for me. And as a palliative care physician, I have worked with public fiduciaries to kind of explain the medical situation and make choices for a person moving forward.
Great. Now, how do you bring up the conversation about potentially needing palliative care with your primary care physician, for instance, or your specialist? It could be either, I guess.
So in my experience, if you said, hey, I'm curious about palliative care to your primary care doctor, they'd be like, great, I have no idea how to get that to you. And if you said, I saw some lady from TMC talk about it, they can ask their clinic staff to look into it. If you have a specialist, I would say, hey, I went to this talk and they were talking about this thing called palliative care, and I think I could really benefit from it. There may be pushback. You're not ready for that yet. And then you can say, I think I know more than you, Dr. So-and-so, and I'm not talking about hospice. And just kind of tease them gently. And just say, no, like really, I would like to talk to someone about my wishes for the future, or I have some maybe symptoms that I don't think are adequately being addressed, and I'd like to talk to someone about that. And this is a service that I know is in existence. I have been in Tucson long enough to where I will get random text messages being like, hey, someone's asking for this. How do I get them that? So your doctors have a network and a community where they know how to ask for things. But I think that's probably the best way to get it for yourself or a loved one, is to ask about it and be empowered that you know what it is and you know what it isn't and you know that you want it. And so you can ask for a referral, or if you're in a hospital, you can ask for palliative care as well. So TMC has an inpatient palliative care team. Banner has a great palliative care team. And then a lot of the other hospitals have other networks to get you palliative care as well.
Okay. And are there any tips or advice that you can provide for people who may have a family member that isn't happy that you've made these decisions? And I know that oftentimes comes up with hospice, right? People, because they sort of know what hospice is. They may not know what palliative care is, but is there anything to sort of help them to understand better?
A lot of times I say that palliative care is an extra layer of support. It's really hard to say you don't deserve an extra layer of support, right? It's kind of, I would like an extra layer of support because I'm going through a serious illness. It's really hard for people to say no to that. So that's one way to describe it, just as an extra layer of support. And that is something that everyone could benefit from. I also have a lot of patients tell me, well, like, I don't want to, I actually had a patient tell me this today. Well, I don't want CPR, but my son really wants me to because he doesn't want me to give up. Well, I don't see it as giving up. I see it as taking information in and making a choice based upon what is going to help you get to where you want to go. And so I think it a lot of times is not necessarily choosing one thing or another. It's not giving up or not giving up. It's not even fighting or not fighting, which I think is very personally dangerous language in medicine. Fighting or not, we're always fighting. It's just maybe we're fighting for something different. Maybe we're fighting for being at home instead of being in the hospital. Maybe we're fighting for more time with our loved ones instead of more time in a chemotherapy chair. You know, the fight is never gone. No physician is ever asking you to give up or stop fighting. We are just trying to empower you to make sure that you are getting what you want and that you are making the informed choices based upon not only what you want, but what your body is capable of and what medicine is capable of. Because we love, I think, in America as a culture to think that we can fix everything, but we can't. And a lot of beautiful healing can still happen even when a cure can't. And so we never stop caring for you. Our care may shift its focus.
Yeah, and it does sound, it's exactly what you said. It's all about achieving your goals and empowering yourself to help with those goals. I love your slide on palliative care and hospice and how it's, you know, this all-encompassing. So when somebody is on palliative care, I know with hospice, you're not doing those life-sustaining treatments any longer. But with palliative care, you continue with that. Is that correct? To what you want, I'm guessing.
The degree that you want to participate in those treatments being offered. So I have patients, I think this is a very classic palliative care example that often shocks people. I had a patient diagnosed with a cancer. It was a very painful location for the tumor. I helped with her pain management, her nausea management, getting her to surgery, after surgery, and then her cancer was gone. So she graduated from my clinic. And that's like perfect. So palliative care helped her with her serious illness. Cancer is a serious illness. It helped her get through her treatment. So she had chemo and she had surgery. And then when she didn't need us anymore, we said, have a great one. Call us if you need us.
That's great.
Yes, chemotherapy can continue, surgeries can continue, hospitalizations can continue, seeing all of your specialists, dialysis can continue. I'm trying to think of other things that often come up. Heart failure medications, heart procedures, all of that type of stuff. But also, let's say something changes and maybe you don't want dialysis anymore. We're there to facilitate that conversation.
Great. Thank you so much for sharing all about this. I love hearing about the clinic, the mini clinic that we have right now.
We just got a question live.
Yes.
Where is the clinic? The clinic is at the TMC Beverly Clinic. So it's actually just across Grant from the hospital, down the road a little bit.
And if somebody wanted to make an appointment, how do they make those appointments? They're referred or?
Ask your primary care physician or your specialist for a referral to the TMC 1 Beverly Palliative Care Clinic.
Wonderful. Okay. I want to thank you so much, Dr. Semmens. That was wonderful. It was a great overview of what palliative care is. I'm going to turn it back over to you to take any in-house questions, and I'll wrap up online. So thank you.
Thank you.
Thanks so much for being here today. We will be back tomorrow for our next class, which is the wisdom of women. That will be on Wednesday, May 17th at 2 p.m. with Trish Chilton from the University of Arizona's Department of Psychology. If you have additional questions today regarding the palliative care talk, I wanted to also share with you that we have somebody that comes to TMC for Seniors that will help you with your advanced directives. So if you need some help completing your advanced directives, you can always give us a call at 520-324-1960 for an appointment. Thanks so much for being here.